I'm going to start introducing you to the wonderful Dr. David Walton. I've heard a lot about him from actually Jim Elliott, but this is the first time we've met this weekend. It's been a big weekend for me meeting people I know remotely. Okay, so David Walton is an associate professor with the School of Physical Therapy at Western University in London, Canada, an honorary associate professor in the discipline of physical therapy at the University of Sydney in Australia, an associate scientist with the Lawson Health Research Institute, associate editor for the scientific journal Musculoskeletal Sciences in Practice, and director of the Pain and Quality of Life Integrative Research Lab at Western. A past winner of the Early Career Researcher Awards from both the Canadian Pain Society and the Ontario Ministry of Research and Innovation and a national mentorship award from the Canadian Physiotherapy Association. He currently holds the titles of Western Faculty Scholar, Western Teaching Fellow, and Mayday Pain and Society Fellow. Following a 10-year career as a clinical physiotherapist, he returned to academia, where his greater than 80 publications span the areas of pain assessment, mechanisms of acute to chronic pain transition, critical reflections of PT practice, professional education, and knowledge mobilization.
On with it, right? Oh my God.
Are we done?
Oh, we're done.
Oh, no. Oh, hold on. He's a martial artist and a father of 2 daughters and a fan of the Toronto Blue Jays.
There you go. That's where you should have started, really. So I see I've got the coveted second to last session, by definition, the penultimate session, which means our next panel is the ultimate session. I hope we're all going to be here for that. I am absolutely thrilled to finally make it here to San Diego. I was invited last year, and unfortunately, partly due to that whole piece about having 2 daughters, I was unable to make it. But this year, the stars sort of aligned, and here I am. So thank you to Rajam and the whole organizing committee for inviting me down. As you've heard, I'll give a few little disclosures here. So I do collect my salary from Western. I do some editing for a journal. I do some traveling around the world. I'm quite fortunate to be able to go and talk to clinicians mostly about issues around pain and all that sort of thing. I just want to acknowledge that I do hold a provisional patent on something that I'm actually going to talk about briefly today. And so there's going to be a slide I'm just going to ask you to not take photos of or tweets. In fact, it'll be a little thing at the top of that slide. And you can see my research funding. So I started as a clinician, as a physical therapist for 10 years, and I have since returned back into academia. I've held my position now. I've had my lab now for 10 years. And I guess the other thing I will say, as you've heard a little bit, and I've been told quite rightly that I am a terrible self-promoter, and I fully get that. I'm entirely aware. However, I feel compelled to recognize the work that the publishing group has put into this book. So I will just acknowledge I have a book available. This is the last time I'm going to talk about it until the very last slide. If you see it out there, go talk to Mary Law. If you like it, great. If you don't, leave it. We'll just leave it at that. A little bit about me. I'm not sure I'm not the most active person on social media anymore. But my lab is really, I call it an integrative research lab. What I like to do is take people from all sorts of different backgrounds and sort of look at what happens if we put them in the same room and kind of force them to spend time together. Maybe some really creative solutions will start to emerge to some really complex problems around pain. My primary foci, my primary areas of research are around measurement science and measurement theory. So I grew up as a measurement scientist in the academic world, predicting and preventing chronic post-trauma pain, critical reflexivity on sort of what exactly rehab is and perhaps where we're going with it. And then I have a whole sort of arm around knowledge mobilization and educational research. So that's enough about me. What I'm hoping to do over the next 42 minutes and 35 seconds is describe what we currently know about the genesis of chronic or persistent pain after musculoskeletal trauma. So you heard Melanie Noel yesterday morning talking about the pediatric experience. I see these people now as adults. So I work with sort of 18 and above. We're going to spend a little bit of time just looking at some of the theories that explain the risk of non-recovery, that is why some people might recover and others don't. And then I want to talk about some of our recent work in understanding some of those mechanisms. There's a fourth sort of hidden bullet in here that I haven't added, but that is that at the end of this, I want us to maybe engage with some different ways of thinking about some of these topics and different ideas around what it means to say somebody is at risk or not at risk. So let's start with what we know. And as a researcher, this is a sort of weird, hard thing to say, right? Because I live in a world of 5% alpha error rates and 95% confidence intervals. So we know very little. However, what I'm going to say is that consistently, when we look at recovery trajectories following acute MSK trauma. So in this case, this is from Michelle Sterling's group in University of Queensland, looking at recoveries from whiplash injuries. And I just want to quickly show you what we've got here. What we've got is a 12-month follow-up. And we've got NDI, so Neck Disability Index scores. People are familiar with that tool. Starting from within 1 month of injury, following through, and through some lovely statistical wizardry, identified 3 trajectories that people might follow following an injury. So we'll have about 45% of the group have mild symptoms and generally recover. In fact, they generally recover by about 3 months following the injury. A middle group of 39% in this case that sort of started mid-range, showed some recovery, but still had, we'll call them moderate disability symptoms by 12 months. And then a group, relative minor, 16%, but they started with a high disability and they maintained that high disability. And when they repeated this with a different outcome, in this case, post-traumatic stress disorder, or symptoms, I should say, post-traumatic stress symptoms, also found 3 recovery trajectories. So when I say found, I mean they didn't go in saying, show me 3 recovery trajectories. This is if anyone's familiar with the concept of a cluster analysis, this is like a cluster analysis to say, what do the data show if we feed it into the computer and hit the button, and the computer says, we can best describe recovery by virtue of these 3 trajectories. As it turns out, these 3 trajectories, or these sort of 3 different endpoints, are fairly consistent. Here's a group looking at low back pain and 678 injured workers, again, over the course of a year. And while they've kind of got a few different sort of some fluctuation in there, on balance, by 1 year, we can again say that we've got, in this case, only 12% of people who actually experience what we might call sort of full recovery, 45% continuing to report moderate symptoms, and 43% continuing to report increasing or high symptoms. That's pretty damning. That's quite large. And across groups, here's another group that followed over 1,500 people. And I don't need to belabor the point, but once again, we can identify by the 12-month outcome, actually, sorry, this is 12-week outcome. Nonetheless, we get a group of people who recovered well, someone sort of in the middle, a group of people in the middle, and then a group of about, in this case, 15%, 16% that did not recover well at all. And finally, some of our work coming out of our lab, along with my colleague Jim Elliott at the University of Sydney, by way of Northwestern University in Chicago. This is a mixed sample of people with any kind of non-catastrophic MSK injury, neck pain, back pain, sprains and strains, wrist injuries, ankle injuries, that kind of thing. We just threw them all in, and we included both Canada and US populations in this case. Once again, lo and behold, 3 different recovery trajectories we can identify. Here we see we've got about 35% of people who, again, recover quite well by that 12-week period. We've got a group of 19% who start high, and this is actually an interesting finding here. That is to say, we can't simply predict somebody's final outcome necessarily by knowing where they start. There is a group of people who do improve, and then 46%, again, somewhat damning, who don't really show a whole lot of recovery, at least will continue to report some degree of functional interference. The y-axis here, I'm realizing I didn't put, is percent functional interference. So if I say what we know, I mean, it's always great when we see consistencies. So these kinds of trajectory studies are becoming somewhat compelling that we can sort of predict people are going to follow one of 3 trajectories following an MSK injury, and these are acute MSK injuries. And I've kind of hedged my bets here a little bit because I've given some fairly wide ranges of these proportions, but let's ballpark around half of people are going to recover reasonably well, maybe regardless of the body region, or possibly even regardless of the outcome being measured. And the other half are going to maybe continue to report some degree of symptoms. And of those, let's ballpark again, maybe 20%, 15 to 20% will be quite severe and are the ones that we're going to see in our clinical practices for sure. Now, when I got into my PhD work initially, I thought I was going to come in and I was going to, create the next hottest intervention for chronic pain management. But I quickly realized we don't know what causes chronic pain. It was really hard to sort of come up with an intervention if we didn't know what the cause was. Now, the question is, surely we're getting better, right? We must be getting better at intervening with these things. And I think you've heard it already this weekend, that not really. This is a group I've just went and pulled out some sort of like, listen, I've cherry-picked this. Some results of some Cochrane reviews, looking at neck pain, low back pain, spinal pain, for a whole bunch of different types of interventions, patient education, electrotherapy, exercise. I mean, on balance, if you look across our intervention trials, sorry to say it, there's not a lot of evidence that points to the fact that we have a strong effect. And I'm using the sort of royal we here because I've even included like intra-articular injections and radiofrequency neurotomies. So there's a bit of a problem, right? There's this problem that we can identify these people who are sort of on these poor trajectories, but we really, so far, don't have a great way to intervene, at least according to the research. And I believe it was Neil brought this up yesterday as well, so if I've given just a slightly different version of the global burden of diseases studies. And I'm just going to highlight once again, these are 315 different types of diseases that people will live with. They use this health economics metric called either health-adjusted life years, quality-adjusted life years, that sort of thing, really looking at burden. And I just want to highlight that in some cases, if we go from 1990 to 2015, you can see malaria, for example, tuberculosis. There's been some pretty significant investment in these. And indeed, the relative burden of those has decreased. But as Neil quite rightly pointed out, when we look at all-cause morbidity in this case, neck and low back pain now has gone from the 12th most burdensome health condition in 1990 to now the 4th. So if anything, not only are we not doing better, it seems as though we're getting worse, or at least in relative terms, we're getting worse. So that's kind of a bummer. And it's especially a bummer when we think of like all the awesome technology that's available to us today. I would think that with high fidelity imaging, with like point of care genotyping now, with robots doing surgeries, with augmented realities, I mean, the world is a wonderland. And yet somehow we're still missing something. So I have to give some context here to this next slide, and this is kind of what kicked me off down this path. So back around 2008 or so, I was doing a talk in San Antonio. It was a manual therapy conference there for APTA. I was doing this talk on whiplash injuries. And at the end of it, this fella sticks up his hand, and he says, "Y'all ever looked at whiplash and bull riders?" I'm like, "No, I live in London, Ontario. We don't have many bull riders." But I said, why do you ask the question? He goes, "Because we never see it." Really? So sure enough, as you do, I went home and popped on the YouTube.
Now that's what rejoice. Gordon. Yeah. Oh no!
Yeah, okay. Looks like the thorax and head are moving.
Coconut baby right here. Oh, hang on, Goose. Yo.
And I looked at another
Goes down
group.
to the other end of the
Another
arena.
group of people who don't seem to develop whiplash injuries.
I did what I wanted to do, and I took out 311.
I don't even think they're wearing seatbelts. And we got this group over here. Oh, that was such a good album, wasn't it? So here's the thing. If you can go right now, you go to PubMed, and you can take a look at things like rodeo riders and whiplash. You can look at derby drivers and whiplash. You can look at the headbangers whiplash phenomenon. As it turns out, persistent whiplash is not even like in the top 10 types of injuries that bull riders experience, for example. Despite it looks to me, from what I understand of, let's say, a car crash or any kind of trauma, there's clearly a transfer of force, say, between the thorax and the head going through the neck. So this gets me thinking, because I wonder what is different about that, whoops, here we go, than this kind of thing.
This is it, man. An opportunity for big shots, man. This is,
So,
man,
what?
I had a couple jokes.
Just keeps driving. Welcome to America. I don't know. What's the difference? They both involve clearly a transfer of energy between the thorax and the head. Did I hear someone say the situation? Expectancy? Conditioning? Now, I think I'm speaking probably to the right group here. I'm kind of preaching to the choir, that all of you kind of get this, right? But maybe if we go back and look at the results of those randomized controlled trials, which of course is how we all treat, isn't it? We just have patients come in and we just assume they're all created equal. We randomize them to 2 different groups. And I flip a coin on treatment. You guys flip a coin on your treatment? Right. So clearly there's something else happening here. And so this is what led me down this pathway of exploring the experience of trauma on top of the experience of distress. You'll see what I've underlined here. And I think this becomes really important. I'll probably come back to this at some point. None of us encounter trauma, whether it's a car crash, a work injury, a slip and fall. I walk through the door and stub my toe on the door frame. None of us experience that trauma in a vacuum. And what I mean by that is we all bring our own biologies, our past life experiences, right, our mood with us to that trauma. And I'm going to be fortunate. I don't know, is anyone a clinical trialist here in the room? Oh, thank goodness. Okay. So I can be slightly contentious here, I suppose, if that was a group of people, is to say traditional sort of clinical trials don't often allow for that kind of individuality within their designs, right? If you guys have read an RCT, you know they normally take sort of all people as essentially created equal. There might be some inclusion-exclusion criteria around things like pregnancy and comorbidity, and so, you know, God help you if you should get injured and you're pregnant, because we have no idea what to do with you. Right, and we just sort of, we assume that if our randomization is good enough, then all important confounders are going to be equally assigned to each of the 2 groups. Now, does anyone know where the randomized controlled trial really was sort of first developed? It's agricultural research. So R.A. Fisher developed sort of the first version of what we now think of as the randomized controlled trial on an experimental farm in the UK. And in agricultural research, this sort of makes sense. It kind of works, right? I can have 2 rows of corn, I can have row A and I can have row B, and I can give row A fertilizer 1 and row B fertilizer 2. And chances are they'll get the same sun. We can make sure they get the same water. I can have someone else come along later on who doesn't know which row got what, and they can take out their measuring stick and they can say this stalk is taller than that stalk. But of course, what we recognize is that the corn doesn't have to go home and pay its bills and prepare meals for its kids and, you know, deal with all those other things in life that we often do. So this got me thinking, how can we start to explore these things? So one of the questions I might have, if I say that no one encounters trauma in a vacuum, is who were these people prior to the trauma? I don't know about the rest of you, but I rarely see people until after they've been injured or surgically repaired or ill or whatever the case. It's rare that I get to know them beforehand. Is that generally the case here? Is there anyone that would see people routinely, like I don't know if anyone here maybe has a practice where you see people serially over time and you might know them well and then they get injured? A few people do. Okay, great. So you might be lucky in this case. And then of course this other question of why is it that, you know, 2 people can be sitting out here at the stoplight waiting to turn in for that nice fish and chips place over there, and that car can get hit from behind, and despite experiencing the exact same mechanism of event, those 2 people can take very different pathways afterwards. So these are the kinds of things that started driving my thoughts. And certainly started from a well-recognized model, the fear avoidance model from Stephen Linton and Johan Vleien. And I suspect many of you have probably seen this, suggesting that the genesis of chronic pain starts at the injury. We experience pain, and then we can take one of sort of 2 different directions, right? We can have no fear, we can confront the problem and recover, or we can catastrophize about the injury, and we can go through fear avoidance, hypervigilance, disuse, disability, that sort of thing. This model, with certainly nothing but respect, really drove a lot of pain research forward. Right? When this was proposed sort of around the late 90s, early 2000s, this allowed us to ask some really interesting questions, and certainly the field of sort of, we'll say, psychological drivers of pain has really progressed as a result. But for anyone here who might call themselves, let's say, a physical therapist, for example, you're probably noticing that there's actually no really physical aspect to this, with the possible exception of disuse eventually. That the model basically says that chronic pain is driven through maladaptive cognitions. Right? And I think it's time, and I don't think this is overly contentious, it's probably time that we sort of build upon this. You know, other things that it doesn't do is it doesn't consider who the person was prior to the injury, places the genesis of chronic pain fully within the injured person, doesn't really consider the social contexts within which the injury occurs. And there's really no room here for biological drivers. I guess the other thing I'll say is there's no clear definition of recovery, and we might get to that another time. Now, far be it for me to say, hey, I've got a better idea, but we tried to have come up with a better idea. So this is a model that my friend Jim and I published a couple of years ago. And what we did here is we sort of took the same general thing where we said there's a traumatic event, and you can follow sort of one of two different pathways. One has this sort of transient and adaptive stress response. And what that means is we should all experience a little bit of distress, right? If we've been injured, whatever, we should all experience. If you're completely flat, if you have no affective reaction at all, I'm equally bothered, right? So we should all experience a bit of an adaptive stress reaction to an injury. Hopefully we draw upon our own personal resiliencies, our adaptabilities, and ultimately we can do something which I've actually called resume a satisfactory life trajectory, rather than the term recovery. On the other hand, we might take this sort of expanded, complexified version of the vicious cycle here that really starts mostly with this dysregulated stress response, and that's kind of what I'm going to talk about today. You'll see other aspects here, sense of victimization, threat, anger, that kind of thing. The other thing we did with this model, you're welcome to, I'm not going to walk you all the way through it, but the other thing we did with this model is we added in these things we've called diatheses, and we actually borrowed that from an earlier model from Dennis Turk, a stress diathesis model. And what we said is that, again, we recognize that everybody approaches trauma, encounters trauma with certain types of vulnerabilities and certain protective factors. And in fact, those vulnerabilities and protective factors are probably different depending on the context of the injury, that in one context, a certain piece of ourselves might be protective, and others, it might be a vulnerability. And I think of, for example, some of the refugees we've had coming from overseas into Canada, and I know into the US here as well, people who have gone through just terrible experiences, and yet somehow some people come out stronger for it, and others are broken people. So it's not even just necessarily we can point to the event itself, but there's something about the person. So what I'm going to do today is I'm going to sort of focus more on this idea of the stress response, because I think it fits with what we're talking about here, and then give you a bit of a clue as to how we're trying to better understand who these people were prior to their injury before they come in to see us. So let me go back to these are, again, our trajectories. This is a project we've finished recently called the SYMBIOME project. It's an acronym, Systematic Merging of Biology, Mental Health, and Environment. And one of the questions we might want to ask then is, what's happening shortly after these people were injured? Now, for context with this study, both we in Canada and my colleague in Chicago had research assistants sitting in the emergency departments and waited for people to come in through the doors who had just been injured, as long as it was non-catastrophic, so as long as they didn't require surgery or hospitalization. After the medical team discharged them, and literally as they were heading for the exit of the hospital, my RA goes whoop, and tries to intercept them. And right there within the hospital, so it could have been within hours to up to 3 weeks, we asked them how much pain they were in, how distressed they were experienced, or how much distress they were experiencing, and we took some blood and some saliva from them right there. And then we sent them home with a much bigger package of questionnaires. It's amazing how much people will do when they're getting paid for it. So they fill out all sorts of questionnaires, gave us additional samples of saliva. We wanted to get the cortisol waking response, if anyone's familiar with that. This is the spike in your cortisol from the minute you wake up to about 30 minutes later. Your cortisol kind of spikes like this, and then it dwindles off over there. So we wanted to know what that waking response looked like. For those who were keen, we took some of their hair, and we also got stool samples. And I will say that as a physiotherapist, that is not a world I ever thought I'd be inhabiting. I had, for like months, a freezer full of human poo in my lab. And I just went in every Monday morning hoping there was not a power outage over the weekend. I got to share this story with you. It has nothing to do with what I was about to talk about, but I think this is hilarious. When I'm working with the group that I do who does the stool analyses, they said, we've had people, one guy brought in a shoebox with elastic band around it for his sample, and they were like, we're not touching that, man. That's not what we're looking for. You never know what you might get. But I'll explain to you why. Why am I looking at this in a minute? So Back to the story, I know, crazy. So back to the story. The question is, what can we figure out about who these people were or what's happening shortly after their injury? So the first thing, of course, as you always do, as a graduate student, everyone knows you do a systematic review. That's always a great way to start your thesis. And so my very first systematic review, this was actually an update of it, was doing this sort of meta-analysis of all the potential risk factors following, in this case, whiplash. And these were risk factors for chronic pain or poor recovery. And I just want to quickly highlight things here. We've got on this side of the table, those things that we had high confidence were in fact risk factors for the later genesis of, I'm going to say, no, let me take that back, for continuing to report pain 6 to 12 months later. I almost said the genesis of chronic pain. That's dangerous. Continuing to report pain 6 to 12 months later. And you can see things here. It's high pain intensity, high neck-related disability, post-traumatic stress symptoms, catastrophizing. For some reason, cold hypersensitivity in this group. We're not sure what that means, but it keeps coming up. And mechanical hypersensitivity, in particular, when we test pressure pain detection thresholds in people with whiplash injuries, we test it both over the upper traps and over tibialis anterior as sort of a distal control area. And as it turns out, those who, for whatever reason, are sensitive distally, which we think might be an indication of sort of some kind of a central nociplastic process, these people earn membership to the higher risk category. If you look over on the side of the table where we're pretty confident these things do not predict outcomes, most of them have to do with parameters of the event itself. And this paper is getting a little bit long in the tooth, so I just went and found an updated one. This was done in 2017. But once again, you can see pretty well the same results, right? So again, high post-injury pain, disability, whiplash, and cold hyperalgesia, anxiety, catastrophizing. And this group also found compensation and legal factors. Similarly, they found no association with a variety of things, including imaging findings and, again, collision findings, collision factors. And actually, we just recently published a paper in PLOS One last year where we had engineers go out to the crash, and one thing they could do is they can stick a little USB in the black box in your car. I don't know if you guys all know you have a little event data recorder in your car, as long as your car has an airbag. And from that, we can take, at the time of impact, how depressed the accelerator was versus the brake, the angle of impact, the direction of impact. You can take this from this little black box. So we could actually get quantifiable metrics off of that. They also took photos from all angles. We got damage estimates. And long story short, none of it had any association with clinical presentation. I'll give you the take home on that one. So again, it begs the question of what is happening with these people. So one thing we're confident in, I would say, by this point, is that the best predictor of any outcome is always that same outcome at baseline. So remember I told you the high pain intensity, high disability, they're the two of the most consistent predictors of a poor outcome. That might be because we often define outcome by pain intensity and disability. Now that's just both statistical as well as commonsensical, I think. But of course, that begs the question of whether this helps us intervene. And unfortunately, we're at this stage, and I'm going to tell you right now, I'm going to show you how, that we can accurately identify the person who's at high risk of non-recovery right now. In fact, we've been able to do it for a few years, I would say, with at least 80% accuracy. And I'll show you ways we can do that. What we have yet to be able to do is prevent that. And that's unfortunately problematic. Now, I say we, the royal we, the research world we, that I inhabit, have been unable to show consistent evidence that we can prevent that. However, I'm willing to bet Tim Hortons donuts to dollars here that if I ask clinicians if you can prevent a poor outcome, you would say yes, which really, again, opens up some interesting conversation about how we research this group. But as of right now, we can identify the high-risk group, but we're not sure if that helps us actually intervene. So because of the results of these reviews, you could say, well, some people might really choose to focus on the event of the collision itself. What interests me more is the person. Incidentally, has anyone ever heard of the website This Person Does Not Exist? Yeah, so they just, it's AI generated, like artificial intelligence generated people. So if you're ever looking for royalty-free images of people, go to This Person Does Not Exist. This is not a real person. This is artificially intelligent. This is AI generated. So I'm interested in what the person themselves and the context within which this trauma has occurred. So the first attempt that we tried to do to identify risk of poor recovery is our Traumatic Injuries Distress Scale, which we short formed the TIDS, which demands careful enunciation, the TIDS, that is a 12-item tool that has been designed from the ground up, intended for use with people with acute MSK trauma. So unlike, say, the pain catastrophizing scale, which people have tried to sort of shoehorn into the acute stage, but really is actually designed for chronic pain, this was designed sort of from the ground up for it to be used in acute pain. What we wanted when we created this scale is an item that, as a tool that not only helps us identify the higher risk patient, but also gives us a bit of a reason of why they might be at high risk, right? Because to simply say, sorry, you know, you're female, you're over 40 years old, you have no education, sorry, you're at high risk, doesn't really help very much. So we really tried to focus on identifying the reasons for the high risk, and so by doing that, we had these individual subscales in here. So the TIDS tool, which incidentally is freely available if anybody wants it, you can get it from my website, I think it's on the very last slide. It gives you a score of uncontrolled pain symptoms, so it might be that somebody is at higher risk of non-recovery because they feel they can't control their pain. Negative affect, which is they may be at higher risk because they feel as though they're depressed, they're angry, that kind of thing. Or intrusion and hyperarousal, which would predict sort of more the post-traumatic stress disorder and that kind of thing. And as it turns out, when we relate these scores to 12-month outcomes, so just for orientation here, I've got the baseline score, in this case it's less than 4 weeks, and then we've got functional interference 12 months later. Nice correlation there. If we call pain severity our outcome, decent correlation there. If we call post-traumatic stress symptoms our outcome, decent correlation there. So by and large, what I'm trying to say is the scale functions reasonably well. We've actually done this now in multiple cohorts. As I say, I make absolutely zero money on this, which business people tell me is a terrible business plan. Nonetheless, it's free if you want it. We've got a user manual on my website, which would show you something like this. Sorry, I'm one slide too early. As it turns out, this scale also helps us discriminate between these 3 different trajectories. So, not surprisingly, people who are not terribly distressed by their trauma are more likely to recover earlier. You could also argue that in the opposite way, which is to say people who have less pain are less distressed. It does also, however, and this is important, give us an opportunity to discriminate between these 2 groups. That is to say, somebody who maybe starts with higher disability and is still going to recover by 12 months, and those who perhaps are not. So this is the thing you'll get if you should go to the website. And it's a nice little decision tree. What it shows, and this was really important to us, I wanted to make sure that if I said somebody was at very low risk of persistent problems, I wanted to be pretty accurate. Because those are the people that if we're wrong, they do not get intervention that they could have otherwise used. On the other side, making an error of saying the person might be at higher risk, and if we're wrong there, all that means is they maybe got some intervention they might not have otherwise needed. So you can see our accuracies there, our positive predictive values, if anyone's really interested. But of course, this still begs the question, and this is the way my head sort of works, is we can predict the likelihood of patient circling numbers towards the right-hand side of a form, and I'm assuming most forms we use measure how terrible somebody's experience is. It's rare that we measure how good their experience is, isn't it? So if we can predict the numbers they're going to circle over here by virtue of how many numbers they circle towards the right-hand side of that form earlier on. So I guess it begs the question, are people just circling the wrong numbers on our forms? How can we, in fact, build in better understanding of who these people are and what else these numbers might be telling us? And this is where we're going here. Most of what I'm about to present has yet to be published. So you're getting first crack at some of this, but that also means it hasn't gone through peer review. You are all critical consumers of knowledge. I just want to keep that in mind. So back to our SYMBIOME study. If no one encounters trauma in a vacuum, how can we better build this into our understanding of pain? As it turns out, we capture a lot of things in this study. One of the things we capture is something we consider sex by gender interactions. And so we include sort of sex at birth, which as we all know is no longer simply a binary thing. And we also include traditionally genderized traits, which is a term we're actually trying to change right now. But it measures things like nurturing, leadership, aggression, all these sorts of things. As it turns out, we might be able to predict sort of pain severity, for example, and associate that with nurturing traits, but only in females. So it turns out not everybody is created equal. Again, research rarely separates out the effects of things on males and females. We thought, okay, that's kind of neat. Let's keep on going. Let's look at things like how stressed people were prior to the injury. So another question we asked them is, what different stressors do people experience in the 6 months prior to their injury? And we had this question of, okay, well, I suspect that the more stressed somebody said they were in the 6 months prior to their injury, the more pain they're likely to report following an injury, and that in fact was the case. But that seems a little bit too easy, so we looked at some other mediators, and we found that the actual effect here was that people who were really stressed prior to the injury also said they weren't sleeping very well following the trauma, and it was in fact sleep that was predicting pain, that the stress pain severity path no longer became significant. We tried to look at something in the blood that might indicate stress as well, so we looked at C-reactive protein, which is an indicator of systemic inflammation. While again we saw that pre-trauma stress did relate to CRP, CRP did not relate to pain severity in this case. Okay, so that's kind of cool. So we're now trying to go back in time. We're still reliant on self-report and recall, of course, right? There's no way to know that. We can't actually go back in time. We're asking people what they were like prior to the injury. Here's another thing we thought we might attempt. We knew that our TIDS score predicted pain interference. I've already showed you that. We also include a tool called the Brief Illness Perceptions Questionnaire. And I'm not sure if people are familiar with that. It's a tool that measures something called illness representations, or think of it as threat appraisal. How threatening do you appraise this experience? So it asks things about how long you think it's going to last, how much of an effect it's had on you, all these sorts of things. Here, not surprising, just to help you walk through this, the more threatening people appraise their trauma, the more distressed they are by it, and both of those things, in fact, predict how much interference they have. That shouldn't be any surprise. But, and it turns out we're kind of coming full circle back to Melanie's work, what we also built in was the Adverse Childhood Experiences Questionnaire. So we also capture this on all of our patients. This asks about trauma. You actually heard this over the course of the weekend. This asks about traumatic experiences prior to the age of 12. This includes physical, sexual, emotional abuse, neglect, poverty, parental separation, parental incarceration. Now, the things get slightly interesting. Now, again, keep in mind, this is what people were willing to report. We didn't actually go back in time. We didn't go back through their medical records. But those who reported more childhood adversities also evaluated the current trauma in adulthood as more threatening. And once again, it went on to influence distress and interference. But again, going back to that whole sex and gender thing, there's some guidelines out there that are now encouraging all of us to do what's called sex disaggregated analysis, which is, if you can, separate these two groups out. And this is kind of interesting, as it turns out, this adverse childhood experiences to threat appraisal pathway is only significant in males and was not significant in females. Completely unintuitive to what I would have expected. I've got some theories, as so many of these things kind of continue to generate questions, of course, rather than answers. But I think that's rather interesting, and once again, it just highlights that as we are starting to build these predictive models, as we're starting to explore interventions, we probably really need to think about the individual person sitting in front of us. Now, we thought, what about some biomarkers? So far we've been restricted to numbers people circle on forms. One thing I've been interested in for quite some time is the HPA axis. And so I've got a very rough drawing of the hypothalamic pituitary adrenal axis here. And one of the things we wanted to do was we said, okay, we can look at that cortisol waking response thing. I told you about that earlier, right? That spike in cortisol, and that seems to be an indicator of HPA axis activity. So the more stressed you are, the more distressed you are, the more spike you might have. But what I said, I can only get to know that after the person has been injured. Is there some way I could go back in time, you see where I'm going now, to figure out maybe what their cortisol levels were like prior to the injury? And enter my endocrinologist, Stan Van Oom, who says, oh yeah, we do that in hair. And as it turns out, if your hair grows, let's say it's about 1 centimeter a month, depending on how many centimeters of hair you have on your head, now I'd be a terrible subject, as would Lars. But if you've got enough hair on your head, and people have done this now, we harvest it close to the scalp, we need about 100 hairs, and we can separate it up into 1 centimeter segments, and you can actually create a retrospective calendar of sort of systemic average month cortisol. And so what we were able to do there, how cool is that, first of all? This is that kind of golden goose, that opportunity to go back in time. And what we're able to do there is look at the cortisol stored in the hair because of how the hair bulb is so intimately connected to capillaries. Now, I think this is a really interesting cautionary tale. What we found with this study was a very small study. This was proof of concept, like 10 people. and we found that the cortisol waking response was related to pain catastrophizing, and when we normalized it to hair, the relationship got even better. This is one of those situations where I was like, this is too good. Like, this cannot be true. And I talked to my team, and I said, guys, there's no, like, we've got almost all variants explained here. I said, no, let's put it out as a proof of concept. But the reason I encourage you all to be critical consumers of knowledge is that we've done this since, again, with the SYMBIOME study, and now here's our relationship. So I tell you that, I think, in one way, just to say, let's be cautious about early proof of concept findings. However, as it turns out, hair cortisol is still being related to, in this case, it's our TID score rather than the catastrophizing score. So this seems as though there might be something valuable happening in your hair. Of course, we always end up with more females than males in these studies. And Stan says, well, we've been exploring whether we can see the same thing in pubic hair. And I said, Stan, that's your thing, man. I'm not doing that. I'll take it from the scalp. Now, we still wanted to keep going, so I told you we took bloods from these folks as well before they left. And so we had about 115 people in this study. This is our first phase study. And he said, what about a series of different blood markers? You know, the whole world is interested in pain biomarkers. You might have heard about this thing called an opioid crisis, and everybody wants to know, can we identify biomarkers for pain? We decided, why not? We'll take a look at the thing. So we looked at 8 different markers that have previously shown an association with pain, mostly in the chronic pain group. And we wanted to know if there was any association with either pain severity or pain interference. And what I've got here are the correlation coefficients with the p-values in brackets. What you can see, no association. Okay, fine, well, done. But as it turns out, remember that whole thing about not everybody is created equal? When we start to break our groups up, for example, between whether they enter our study with a pre-existing psychiatric morbidity, so a pre-existing diagnosis or not, we see an association between transforming growth factor beta 1 and pain severity in those people who have a pre-existing pathology, but not in those who do not. Not surprisingly, no one encounters some trauma perfectly healthy. I don't know if any of you are perfectly healthy right now. Some of you might experience pain every now and then. We also found that in people who had a pre-existing pain condition, once again, between one of our markers, interleukin-1 beta, and pain interference, we found a significant association, but not in those who do not. And in fact, we looked at 18 such things. And again, keep in mind, some of these will definitely have occurred by chance. Again, I know you are all critical consumers of knowledge, but these are all things that give us a reason to continue searching if we really wanted to find it. 6 out of the 18 things we looked at, and this included socioeconomic status, included age, it included BMI, sex, pre-existing health conditions, moderated at least one association between a biomarker and pain severity. So maybe there's an association out there. And we did look to see whether perhaps they interact. Now, this is the slide you're not allowed to take a picture of. We did, in fact, do a cluster analysis and found that 3 of the markers kind of interact. And I have to be slightly coy here because I actually can't tell you what they are, or else I'd have to shoot you to borrow a line from Top Gun. But there is a phenotype, which is represented in our green line here, who is defined by at least a really high concentration of 2 of those biomarkers. And people in that group also reported significantly higher ratings of emotional and sleep interference at baseline, and also were 3.1 times more likely to report persistent symptoms 12 months later. So of course, as tends to happen when a university commercialization arm gets their hands on this, they want to file a patent, and so that's why we're a bit stuck. However, I am going to break that patent and show you one of those, because BDNF, brain-derived neurotrophic factor, is one that keeps coming up. And interestingly, I've had one of my students, Mohammed Fakhreddin, who said, hey, let's go back even further. Let's look if some people maybe have a genetic predisposition to more BDNF expression following trauma. And sure enough, we found that as well in the blood. So there's a group that's homozygous in a particular gene. Okay, if anyone is a geneticist here, this will mean something to you. Otherwise, don't worry about it. There's a particular gene that codes for the expression of BDNF. In those people who are homozygous with a CC homozygous there, they expressed far more BDNF in their blood, in their plasma, than did the other 2 groups. And we've already seen that leads to higher plasma BDF, leads to higher baseline pain severity, and a poorer long-term outcome. So we are getting at this stage here, and we need to be careful, where we might be able to identify people. In fact, in theory, if I was to ask you all the right questions and sample the right things all from you right now, I could probably develop a pretty good sense of if you were driving home at the end of our session today and got into a car crash, the likelihood you develop chronic pain. Now, I don't say that lightly, and every time I do, I'm reminded of the words of my Uncle Ben, who says, with great power comes great responsibility. We need to be really cautious about this conversation. Thank you, people who laughed at that. I know who my fellow Marvel nerds are. Interestingly, this relationship is only present in, once again, those who did not report adverse childhood experiences. So those who reported adverse childhood experiences, it doesn't matter necessarily, in this case, what your genetics were like. So perhaps one overrides the other. So in my last minute and a half, I want to just kind of give you the story so far and maybe where we're at. So trauma, distress, pain, and recovery turns out are really quite complex. I've given you just like a snippet of the kinds of things we're trying to ask. We are pretty good at identifying the high risk from the not so high risk group. There's some evidence that numbers on a form may tell us something about what's happening physiologically, which is kind of interesting, but there's a whole bunch of these pre-existing, we've called them diatheses, that probably interact to influence whether somebody is or is not likely to recover quickly beyond the mechanisms of the trauma. Other things we're doing, in case you're interested, is we're looking at, for example, sex hormones now. So we've got progesterone, estradiol, and testosterone. We're looking at the salivary proteome. I'm not sure if that's going to tell us a whole lot. It's kind of interesting. And I mentioned earlier the whole poop thing. It turns out the gut-brain axis is an important stress pathway. I was just looking up some work this morning just to pop something up here. As it turns out, the intestinal microbiota, so the different flora in your gut, can affect central levels of BDNF, at least in mice. So once again, we may have a potential pathway here if we want to know it. What I'd much rather talk about, though, if we have time, are some of these items. The ethical, moral, and critical social implications of identifying and communicating risk of chronic pain, whether we really even want to know. Clarifying what we even mean by recovery versus chronicity. As it turns out, that definition is not all that clear. It's somewhat ambiguous. Keeping in mind that everything I've done here has not proven a causation. We've got associations all over the place. There's going to be a lot more work to determine whether these are causative. And I guess even a question at the very end there is, as a society, do we even want or need biomarkers of pain? Lots of funders want to see it. Lots of insurers want to see it. Lots of lawyers would love it. Do we want it? So I will leave it at that. Oh yeah, sorry, my take, there you go. In case we forgot. Hashtag we are not corn. I keep trying to get that trending. Lastly, if anyone wants to connect here, there's that website I mentioned if you wanted to go and download. We've got all sorts of free clinician resources on there. Just a quick plug, I also lead Canada's only competency-based master's level degree program in interprofessional pain management, if anyone's interested. And I guess it's just another reminder that there's a book you can go and see. The lovely Mary Law, who is walking out the door, ready for the deluge of customers. All right, thanks everyone.
That was super fun. I'm a public health therapist. I love pee and poop.
Oh, isn't it the greatest?
So great. Well, it's essential, first of all, but also that you can learn from it.
It turns out you can learn a lot. It took me a while to get my head around that.
Right. Okay. Well, then I'll take actually Brahmjam's question first. What did you find in people's poop in relation to recovery?
Yeah.
I like
Corn?
that you qualified.
Nothing yet. I was hoping to have the analyses done before we got here today. We have the data. It's sitting on the computer back in the lab. The student who was meant to be exploring that is currently trying to madly finish his thesis, so we haven't yet analyzed it. Sorry.
Awesome.
If I come back next year, there will be, if you really want to know about the poop thing, it'll be available. Yeah, okay.
Awesome. Okay, so we actually have two things from Stephanie. One is awesome reference to Tim Hortons.
Thank you. Where's
And then-
Stephanie? There she is.
Then
There we go.
also, how might biomarkers in hair be impacted by folks who bleach and or color their hair?
Yeah, apparently not at all. Not at all. Yeah, good. I had the exact same question, and apparently the answer is not at all. Yeah, in fact, they've been able to assay cortisol from the hair of mummies, Egyptian mummies. So it sticks around. It's pretty robust. Yeah.
Were mummies stressed?
I don't know. All I know is they can do it.
Okay, then from Joe Hanley. From a clinical perspective, is there concern that classifying someone as high risk of non-recovery, do we create a sort of self-fulfilling prophecy by the way the clinician approaches the patient treatment?
Absolutely. Oh, I'm so glad. I'm glad that question came up. I kind of tried to prime that question. And I would actually, I think this is a great opportunity to have a discussion. I know this isn't the greatest forum for open discussion, but I really think that would work. That's a really interesting question, an important question we need to ask ourselves. It seems to me that there is a group of people out there who want to know their genetic risk of all sorts of things, for example. And there are a group of people who don't. And if just, the ubiquity of 23andMe and Ancestry DNA and whatever tells us that some people want to spit in tubes and send it off and get a sense of whatever their genetics are like. And they might want to know, through doing so, whether they're at risk for any number of chronic health conditions. And others don't want to know. And I think there's something really interesting in that might help us answer this question. I don't think there's a blanket statement I can offer here. If I was at risk of, I often wonder what my prognosis is. So if I was at risk, of cancer, I might want to know that. Other people might not want to know that. If I got injured and I want to know, what's the likelihood I'm going to recover? If I'm asking that question, clearly I want to know. Now, does it become a self-fulfilling prophecy is a critical question here. I will say that in the studies we've done so far, because we didn't know, when we collected these data, we didn't know which of those things were going to predict outcome. None of the patients in our studies knew if they were going to recover or weren't going to recover, and some of them still did not recover. So I don't think that was a mechanism in this study. Could it be a mechanism clinically? Possibly. Makes complete sense. And I think that's why I put that question up earlier. How do we communicate risk? I think that's a question that we all need to think about. An approach might be something like, Mr. Jones, based on everything you've told me today and the things we've looked at and the signs I've seen, if half of people are going to follow a trajectory that looks like this and half of people are going to follow this, I think without appropriate intervention, there's a chance you might follow this one. But, and that's where I think we really need to be cautious here because there's not a lot of evidence we can lean on here, more clinical intuition than anything. But if we intervene properly and we hit the right targets, we should be able to get you back down onto this trajectory. I think that's, as of right now, that's the best way I can kind of get at that. But certainly the conversation around communicating risk, that's why I'm serious, actually. With great power, great responsibility here, we need to be cautious in how we use that.
Okay, and we have time for one more. Put it up there. From Mark Broberg, great talk. Curious if one is stressed enough due to trauma, are they possibly biased towards interpreting childhood events as more adverse?
Yeah, super great question. These are the kinds of things that sort of flow through my heads at night as well. Keep in mind, again, we're asking people to self-disclose childhood traumatic events. What we don't know is how many people are either not disclosing or have repressed those experiences. These people are 18 or older. Our average age was 40. And we're asking them about experiences prior to the age of 12. Now, if they're traumatic enough, people may well remember them. Interestingly, our study, as well as the big ACE study, I don't know if you guys know, the NIH in connection with Kaiser Permanente has been running an ACE study for years. We continue to consistently find about 60% of our sample do endorse at least one adverse childhood experience. 60%. Statistically, that's great. Socially, that's a travesty. So it's conceivable that people are underreporting. I would hope not. We're already at 60%. In this case, I think the question is asking, could people be over-reporting? And that's also entirely possible. I have no way to know how to check that. I don't know who would choose to lie on forms like that, but I'm sure there are some people who do. The simple answer is I don't know, but I think it's a good question, and just keeping in mind that we are necessarily reliant on recall and willingness to report at this stage. Incidentally, we just got funding for a 20-year longitudinal study, which will see me to the end of my career, starting with painful procedures in childhood and following these people up until adulthood. So maybe in a sort of longitudinal trial like that, like kind of a mini Framingham study, we might see something emerge there. But as of right now, we're stuck with recall.
Oh, congrats on the 20-year study.
Oh, yeah. We'll finish it, and then I'll retire.
Sounds like a plan.
Yep.
Okay, well, thank you so much. That was wonderful.
Super. Thank you.
Alrighty, so now is your chance to go get your book signed. And then also, if you can just be back here at 4:35 for our final panel, it is sure to be amazing. So don't miss it.